Right. Obviously, I'm not Laura McTague. She couldn't be here at the last moment, and I saw these slides about 10 minutes ago, so wish me luck. Some of this, I did hear a bit of Anne's talk, so there's a bit of overlap. But this is, I suppose, just to kind of, what you'd hopefully take away from this is just some ideas of things you might be able to say or where to look to help you with some of that stuff. So, as has been said, you know, a lot of advanced care planning is about the preparation, the conversation, but then the sharing of that information is really, really important. And reviewing that, just like Anton was saying, you know, even for some adults, sometimes the situation changes, people do better than we're thinking. We do sometimes have to go back to that plan, or equally, things get worse. And what was appropriate previously, we need to relook at that plan. So hopefully, we'll go through about who might benefit from thinking about planning ahead, how we might go about gathering some information, a little bit about respect conversations, and where you document it. Some of it's a bit obvious. So I think Anne was mentioning SPICT. We just keep going on about it because it is a really useful tool, because it's probably a bit more useful, or I find it more useful than the surprise question. Just gives you a bit more to sort of hang it on about different conditions, malignant and non-malignant. So that would be one thing just to take away, is some understanding of SPICT. And one of the things in respect, I think, which we all recognise is really poorly done, both in hospital and when we're sending people out to you, but also people coming in, is we're okay at talking about what the resuscitation decision is, but what are our actual treatment recommendations for people? What are we specifically saying? So I imagine you've all seen a patient come out of hospital and it says something like, you know, for level 2 care on, or something like that. It's entirely useless, really. So, I mean, we don't need loads and loads of details, but it can just be a bit more useful to sort of say, what are we actually talking about? Are we asking for someone to stay in a community session as much as possible? There may still be appropriate for some oral treatments, some subcut treatments, even some IV treatments at home. Are we saying that they'd only come back to hospital for something like a fracture? Or are they coming back to hospital for treatments for reversible deterioration, to manage the cause of reversible deterioration? So they get a new pleural effusion, and we're going to bring them back to hospital to manage that. And we've got to write that down. And clearly, like has just been said, respect's not quite the same thing as advanced care planning. Respect is an emergency care plan. There may be lots more detail about what someone's wishes and hopes for their treatment are in their advanced care plan. What can be some further useful information? So on the right, the thing that we're trying to get people to think better about in hospital, which will hopefully help you in the community, is thinking about what is the specialty treatment plan. So it's not quite enough just to say, you know, they've got end-stage heart failure, they're for, you know, symptom control only. We need to know about, well, what about have they got a defibrillator, an ICD? Are we doing anything with that? Or if it's a cancer patient, a lung cancer patient, are you still managing some of the complications of that? Are they still for dialysis? Are they still a patient who might be, suitable for escalation back into hospital for more intensive treatment? So all these things are possible. A respect plan doesn't have to just be someone who's just for palliative care, just for symptom control. This can be really sort of a useful document to plan emergency care, which, as I say, later down the line might need to be updated and changed. I'm going to give an example that Laura uses. So Laura works in a respiratory outpatient clinic. So she works with the respiratory clinicians there, and she's sort of trying to embed herself there to offer some palliative interventions for some of the non-malignant respiratory patients. So she does a lot of managing symptoms, but she's there also to encourage the respiratory team and to do herself to set some goals, find out what matters to you, and do some planning ahead. So she'll do a lot of initially just giving out a respect leaflet, or, you know, meeting the patient for the first time, talking to the consultants there and kind of getting them to take on some of that practice. And she will use SPICT, and so an example of using SPICT to identify who might who might benefit from planning ahead. So we're now trying to get the specialty teams to use SPIC to do that. So you've got someone with advanced respiratory disease who has got severe COPD and is breathless on minimal exertion and is meeting the criteria for oxygen therapy, and they've had a previous admission for NIV. Clearly these things are all indicating to us that this person might benefit from some planning ahead. They may still be appropriate for the further admissions for respiratory support, but we need to think about that. So her first example is a 42-year-old lady who has had ILD for 3 years. There was no further treatment for that. Although she is still on the lung transplant waiting list, we have a lot of these patients who just seem to be on this waiting list for a lung transplant, and eventually someone says, well, no, we're not going to do that. But they're still on the waiting list. She's had admissions, and actually her oxygen requirements are rapidly increasing. She's at a point where, as an inpatient, we should be saying, what treatment recommendations would we now offer for this patient? How would we go about doing this? Whose job is it to have these conversations? You know, clearly it's everyone's job, but someone's got to do it. And so, using SPICT, we can use some of the criteria on there. So she's got on the right here. Is there a pointer on here? Oh, what have I done? There we go. We've got a patient who's got some unplanned hospital admissions, a performance status that is deteriorating. With the breathlessness, may be increasingly dependent on other people for their care. And then when we see those general indicators of poor health, you move across to the specific treatment, the specific condition factors. So for respiratory disease, have they got severe chronic lung disease? Are they breathless on minimal effort? Are they needing oxygen? These are all then triggers just to tell you that this person is likely to be in the last year of life. So this would be a good candidate to have a discussion about it. And then if there's probably one thing I'd say just to try and remember from or look at it at a later date is the red map framework. So this is the kind of the so what or the next bit from SPICT. This is all work done out of University of Edinburgh, and it's really useful because it just gives you a bit of a framework to say, okay, well, we've identified this patient. What am I going to say to them? So the thing that people, I think, mostly forget or often forget in advanced care planning is you and the patient have to be on the same page. You have to kind of both be recognizing that something is going on with their condition, with their health. And if you've not got that shared understanding of what's going on, then it does make the discussion really difficult. If you can get to the shared understanding, then actually it's much easier. So, you know, the using the red map framework, you can just use these questions. Can we talk about your health and care? What do you know? When they tell you what they know, is that what you know as well? Do we know the same thing? Do we need to ask someone else? Do we need to go back to the respiratory team or the oncologist and say, look, you know, is this correct? Have we stopped chemotherapy? Are they not able to have oxygen therapy? Whatever it is. What do we know? What don't we know? And then knowing all that, what's important to you and your family, and sometimes that's very medical things, and sometimes it's not. But you know, getting to the point where we can say what matters, what's important, and that can open up the discussion about, you know, and what matters to you if you're dying, what matters to you if you're not going to get better. Knowing what matters to them, then, well, what can we do about that? What can I do? What can't I do? What will help? What won't help? And can we do some planning ahead for that? So, I mean, it makes it sound really simple, and clearly there's lots of cases where it's not as straightforward as that. But I think if you can get to the point where people do understand what their diagnosis is, and that we think their prognosis might be poor, they might be in the last year of life, they might need some time to absorb all of that, but generally we find they are able to kind of engage in some of that. Some of that can go on to the respect form. So the bit at the bottom is the resuscitation bit, but you know, you can see how some of this maps across. So the summary of the relevant information. Have they got a more detailed advanced care plan or ADRT? What do they value? What decisions should we make? What do I want to avoid? What do I most fear? What's the priority? You know, and I fill in lots of these, and there are patients I have who they are prioritising extending life, knowing that they may die soon, but that's still their priority. It doesn't, you know, it's not wrong for them to want that. We just have to be realistic about what that might mean. this is just sort of saying some of the same things again, isn't it? What do we know about how you are? So my lungs are hard, they're fibrosed, can't get off oxygen, I might die without a transplant. What worries you? I'm worried about dying, I'm worried about leaving my kids, they're unprepared, I haven't spoken to them about it. What do you want? Some people might say, I want everything, including resuscitation, you know, and sometimes that is a difficult decision. The treatment recommendations are not a wish list. They are kind of what are we realistically able to offer, and explain why that might be possible or not. And there are patients who sometimes we don't know what the answer is, and we might need other opinions. But even someone who might want a lot of treatment, then I think Anne was again talking about parallel planning. Okay, well, if that doesn't work, can we talk about what if that doesn't work? I think I'll skip that one. So we've looked at that. So that discussion about resuscitation, it is difficult sometimes. Not everyone knows what resuscitation is, and it's just worth engaging people in a discussion about that. People will often think no cardiopulmonary resuscitation means no treatment. So being really clear what we're talking about. Can I ask if you know anything about it? Has this been discussed with you before? Explaining what it is, and explaining, you know, resuscitation doesn't work if someone's in very poor health or if they're dying, and we normally plan for good end-of-life care. Sometimes it can work, but it can leave you in a worse condition than you are now with particular health conditions. Obviously, some people will choose not to have it, and being really clear about we can't offer this treatment, we can't offer cardiopulmonary resuscitation, but I can still treat your chest infection, I can still give you oxygen, I can still admit you to hospital if actually you have a reversible deterioration. So lots of people think, you know, once they kind of understand that, it can sometimes be easier to engage in the discussion. Again, you know, the CPR decision is on the respect form. So I think my thoughts on this is that, you know, what advanced care planning is a complex therapeutic intervention. It involves lots of different people, and it would be really nice if it could just be a one and done conversation, 10 minutes, we've got the plan, and sometimes it is like that. None of us, yourselves in hospital, really have as much time as we would want to have that kind of repeated discussion, to go back and do it again. But there's a balance somewhere about initiating the discussion, giving some information. Let's talk about, you know, if I'm seeing someone in outpatients, let's talk about this in a few weeks' time when you come back, and we'll talk some more, give you a chance to talk to your family about it. And the other thing is that with these kind of interventions, I think people get quite dejected sometimes in hospital that, well, I've done all this advanced care planning and they've come back to hospital again. And it's not, you know, the number needed to treat to prevent one hospital admission is not one. You know, we need to do these conversations more, you know, again and again with lots of different people. The benefit to me is not so much about preventing them come back to hospital. People will always come to hospital. They'll die in hospital. Some people will die at home. It's giving the people the opportunity to understand what's their diagnosis, what are their choices, what's realistic, what's not, to feel heard, to include their family. Those are the outcomes really than a sort of a place of death. It's kind of it's more complicated than that. So there we go. We've reached the end of the slide. So in summary, hopefully we've covered some of this. Who are we identifying using the SPIC tool? It's really quick, and it just gives you a sort of a quick screening way of kind of working out who are the important people to have this discussion with. When and how to do it. If you try and do it all at once, and I'm guilty of this as well sometimes. I think, this is my, I've got 20 minutes, I'm probably not going to see this patient again, no one else is going to do it, so I might sometimes just go a bit, too much for them. But ideally, can we have a brief introduction? Can you give them something to take away? Can you bring them back and have keep that conversation going? Think about the recommendations that might be there from specialists. I appreciate again that's not always there, but I have to go back to people a lot. We should, if we feel like we need some information, we should be going back to their we should be going back to those condition management specialists and saying, look, can we just have a bit more information, or can you give me some recommendations about what would be appropriate here? would a further admission for IV diuretics in this person with end-stage heart failure who's putting on weight, would that be something you would offer or not? When you're having the discussion, as I say, if you just remember about REDMAP, have a look at it. Some of you might not like it, but there's lots more information on the website, and I really like it. I look at it quite a lot. And then on the respect form, there's not much space, so we need sort of a short summary of what we've talked about. But if there is more advanced care planning information, then we've got to find a way, I suppose, to have some kind of shared way of doing that, and that's the work that Anne was talking about. That's ongoing. So hopefully you can't really see the links. I don't know if you just Google REDMAP, you'll get it, and SPICT.